Hello friends, welcome to Pediatric Basics or welcome back if you have seen our previous videos. We will particularly talk about pediatric bronchial asthma. But having said, these are primarily principles, so it does apply to all age groups. So irrespective of the specialty you are dealing with, you can go through this video. And one thing I strongly believe, which probably I'll keep on talking again and again, is keeping basic, keeping simple, keeping systematic help us all throughout for our exams as well as for the patient managements. So hopefully you will enjoy this video and have some message from our side. Thank you so much. Good morning, friends. Welcome or welcome back if you have seen our previous videos. I always find it more interesting to talk something as a bedside, and we can discuss about the various practical clinical scenarios which helps us to understand and probably a better patient care. Now, bronchial asthma is such a common problem, and then we come across all different kind of situations. So these were actually real life cases which we can talk about. So think about all these three situations which you can see on the screen. A 4-year-old who has been having kind of a recurrent coughing, wheezing, roughly about once in 2 months' time, comes with fever, cold, and he gets better. There are no intercurrent symptoms. And then the second referral we got in our clinic was that, 9-year-old, can you please do the spirometry to confirm the diagnosis of asthma? And the third one, very interestingly, is a 13-year-old with nitric oxide levels of 195. Could you please review him with regards to his diagnosis and further management? Okay, the brief background about bronchial asthma and the severity of the problem. It is said that 14% of world's children and young persons suffer from bronchial asthma with significant morbidity and mortality. And more importantly, the management continues to be suboptimal even in the developed part of the world. And it's always useful to know the impact of bronchial asthma on the life, education, family, morbidity, and mortality from all aspects, really. And that's why the optimized management is so important for these children to have a normal life. Yeah, let us talk about a few things. What is asthma, various trigger factors, a little bit of a pathophysiology presentation, which I'm sure you all know about, and the diagnosis of asthma. Management, I will leave it only to the principals because we can make a separate video to cover the details about the management of asthma. I'm sure you all know that bronchial asthma is the most common chronic inflammatory condition of lungs in children. It is a kind of a heterogeneous disorder where various factors are involved in the pathophysiology and presentation. The three important things which happen, one is reversible bronchoconstriction secondary to hyperresponsiveness and inflammation, and then secondary secretions. It does not follow any Mendelian pattern of inheritance, but there is a significant genetic predisposition in patients who have a strong family history of atopy. Yeah, this is a good picture of depiction of what I just said, that there is bronchoconstriction. So you can see the muscles on the left hand side, they are constricted as compared to the normal side. And then you can see there is a mucosal thickening because of the inflammation. And then obviously there is no secretion shown here, but secretions is again important factor as a part of obstruction. So much more clear in these cross sections about the bronchoconstriction, the inflammation, swelling, and secretions. These kinds of pictures are really useful for two things, I think. One is think about the management and think about this picture. And number two things, explaining things to the patients when they can understand, and also to the carer so that they know what exactly happens in asthma. We all are medical science student, and it's always important and useful to know at least some basic pathophysiology, and that helps in us to understand the disease process, as well as it helps in management as well. Now you can clearly see here what happens in asthma. So there is a kind of a trigger factor which induces inflammation, and that all causes what we talked about in the pictures, and eventually leading to obstruction, the basic problem in bronchial asthma. So as an interest more about this, what happens is a trigger factor, which is kind of an antigen. It stimulates the dendritic cells, which in turn activates the T lymphocytes and producing the cytokine response. The various cytokines which are responsible for the process in the pathophysiology of asthma are prostaglandins, histamines, enzymes, and leukotrienes. Now, trigger factors, which are actually the exacerbating factors as well, are really important for all of us to know, which can become an important part of our history taking to know what is the reason which is causing exacerbation or acting as a trigger. You can see from the list various things. I'm a little bit skeptical about gastroesophageal reflux. Now, other equally important factors are the risk factors, which you can see from the list. Which are always helpful in terms of going through the details and helping the overall management of asthma for the obvious reasons. I believe we all know the clinical presentation that dry chesty cough, wheezing, shortness of breath on the background of the trigger factors we just had in the previous slide, and family history may be there to support our clinical diagnosis. Now the question, how do you diagnose an asthma? So I'll leave the first part, history, on the background. We have a couple of tests. What we know is spirometry and pheno. Pheno is relatively new. Spirometry has been there for a while. So we'll talk about them and then come back to our history. The one thing which I have not included in this at all is the allergy testing, which is primarily to identify or help us to identify the trigger factors rather than diagnosis of asthma. Yeah, allergy testing. So I was just saying that I'll probably not include more details about this, but as a part of a full blood count, you can check for eosinophils, which will help, but it does not diagnose asthma. But if you do, if there is a history of a trigger factor, then you can do those specific allergy testing, and that might help us in terms of the trigger factor and possibly help with the management plan as well. Okay, so the first investigation to help us to diagnose asthma we often talked about is spirometry. It took a little while for myself to understand what exactly the spirometry is. So let us talk about it. No, let us try to make it simple with regards to spirometry. What exactly happens? So there is a computer attached to a small equipment where a patient can breathe into, and then the computer does the calculation of air exhaled out. In pediatric asthma, we are primarily interested in only expiratory lung volumes. So imagine yourself, you have got a balloon and you take a deep breath and breathe out into the balloon. So whatever amount of air which comes into the balloon at the end of 1 second becomes FEV1, and then if you continue to blow till the maximum end, maximum air exhaled out, that becomes the forced vessel capacity. The computer will tell us the figures for both FEV1, FEC, and it also does the calculation in terms of the ratio. Now what will we get from it? One is it will show either it is normal, there are figures we will tell you, and then whether there is evidence of any obstruction or there is evidence of any restriction. Now with regards to obstruction, if we find the evidence of obstruction on this spirometry, then these patients can have what we call as a reversibility test. A child or a person is given the dose of bronchodilator, and then we repeat the spirometry and see if there is reversibility, and the figures which we have should have been better by at least 12% to say that there was a reversible bronchoconstriction. So if you want to use a graph to show what exactly is seen, the purple line is for a normal person or a normal child, and the dotted line shows how the FEV1 and FVC are affected in terms of ratio. Now, to look for obstruction, the normal figures of FE1 to FVC ratio, you will probably find different figures in different places, but overall, generally, it is agreed that more than 75% is normal, and then you can have various grades of mild, moderate, and severe. So basically anything less than 75% is taken as evidence of obstruction. Now there are various factors which can affect the figures of FE1, FVC, and to avoid those biases, a Z-score has come up, which is a statistical figure. I'll be honest, and then I will not give you exact figures here because I do not put my head in particular that. Our spirometry is done by one of the specialist nurses, and she will give me a figure. I will just check that has the technique been good and there have been no other problems, and then we'll accept the figure given by her as a normal or abnormal. So if you think about what we talked about, so basically spirometry tells us about whether there is any obstruction. We can check for reversible obstruction or reversible bronchoconstriction, to be more specific, or whether there is a restrictive disease. So as a principle, spirometry tells about either there is obstruction or there is restriction, and then asthma is not the only cause of airway obstruction. There are other conditions. I'm sure you would have thought before the slide comes up. Now think about other conditions which causes restrictive airway diseases as a part of a differential diagnosis. So they will come up on the slide soon. Now, fractional excretion of nitric oxide. This is relatively new. So let's have a little bit of talk about it, what it is. It has been noted and identified that in the allergic inflammation involving the airways causes release of nitric oxide, and the good thing is that it can be measured. Now this is a relatively simple test which can be performed where a patient or a child as young as 3-year-old can do the test. The air is blown into one of the machines, and the machine will do measurement of a nitric oxide, and then the normal values and abnormal values will give an indication whether a child has got asthma or not. It has reported to have a moderate accuracy, and it also helps in management. It does have a predictive value and a prognostic value as well. Now there is a question mark against the diagnostic, although there are people who say that it has a diagnostic value. So we'll talk a little bit about when we talk about the cases we have seen right in the start. Like every test, this also has got its own pitfalls, and it is to be noted that you can have a false positive test in the following condition mentioned above. So the importance is that we need to know in what circumstances the test has been performed, where the technique was good, or whether any other problems associated with that. Yeah, it would have been interesting to know what are your thoughts about the three scenarios I mentioned at the beginning. Unfortunately, this is one-way talk. So the first child probably has a recurrent viral induced wheeze, and as of now do not have anything to suggest asthma. You can always question or debate about whether he needs any preventive treatment or not. Now the second scenario with a 9-year-old boy, now we can do the spirometry, but what will be most important will be his background history, as we know that spirometry only tells you about either obstruction, so we will have to check for reversible obstruction, and if a child gets a normal spirometry, does not rule out that the patient has asthma, because he may not be symptomatic at all when he came for the spirometry test. Yes, reversible bronchoconstriction is a really good way to support our diagnosis with spirometry. Now the third one is one of the most interesting one. This is very recent one where the 13-year-old has had the pheno test in one of the GP practice setup, and they have done it twice, and this child is on treatment since last few years with his preventers of the inhaled corticosteroids, montelukast, and as and when needed bronchodilator. Now, when I went through the details of history, then he had absolutely no symptoms of asthma at all, and so there were two possibilities. One is either he's very well controlled with his current medication, or he never had asthma or had a very minimal asthma. So these are all different possibilities. Now he has had this FeNO test when he was on a full treatment, and despite that his FeNO levels very high, and this does raises the question whether the FeNO test was done kind of in incorrect way, or there was some problem with it, or the FeNO itself may not be always 100% diagnostic of the diagnosis of asthma. Spirometry and FeNO are important part of the investigation with regards to asthma, and it is the part of many of the guidelines created by American Asthma Society, the British Asthma Society, as well as the European Asthma Societies, and we all understand that. But one of the most important thing, okay, so if someone asks me what is and how do you diagnose asthma, the most important thing is the history. Although the spirometry, if available, and FeNO, if available, can be an important aspect in terms of diagnosis and management of asthma. I just love the word management because practically it involves the detailed history, investigations, and the full treatment plan and continued follow-up as well, and then it just not only treatment. So let us have a look at the basic pathophysiology slide for asthma, and you can notice that there is a trigger factor. So obviously we need to be very clear about trigger factors, if at all there are any, from the history, and that also forms a part of management. That is there any way the triggers can be avoided, or is there any way the triggers can be treated in a different way. Okay, now the second important factor for which is practically kind of a definition of asthma is a chronic inflammatory condition. So treat the inflammation. So how do you treat the inflammation? Unfortunately, NSAIDs can worsen asthma symptoms. So those anti-inflammatories are not useful in management of asthma. So it comes to the steroids. So chronic asthma, you have inhaled corticosteroids, and acute asthma attacks, you have the systemic steroid, which can be primarily oral and sometimes the parenteral forms which can be used. The other important things, if you have noticed from this the pathophysiology, that leukotrienes are responsible as an inflammatory process in asthma. So we have the agent what we call as a montelukast, or maybe there are other related agents which works on the as a leukotriene antagonist, can be used as a preventive treatment for asthma management. And then of course the basic thing of acute attack where there is a bronchoconstriction is use of various bronchodilators. We'll keep the overall management of asthma in a separate discussion, because anything which goes beyond 15 to 20 minutes of talk, lecture or discussion, probably, at least I am not able to retain it, and my concentration is very poor. Memory is worse probably, so it's not going to help to me at least. So that's the reason I would like to keep it at the best less than 20 minutes. Okay, so in principle, avoid trigger factors if possible. Number two, prevent asthma symptoms to the best so that the patient or children can have the normal life. And then comes the treatment of acute attack. But as I mentioned, we will discuss that in a separate video. Okay, I'm hoping that I did not make you sleep through my talk. So thank you so much for your valuable time. It is much appreciated. I think equally important it will be, if you think that it is useful, you liked it, please do not hesitate to like, share and subscribe. And more importantly, your comments If something you know new about asthma, it will be useful to share with everyone. Thank you once again.